I thought perhaps we could consider some cases. I've come
Yes.
with some cases, and I thought maybe you can give me your opinion about whether it would be
Alright.
appropriate in these sort of cases. I know we talked about that one ought to monitor and make sure it is
Yes.
safe for certain groups. Certainly,
Yes.
you'd want to make sure that the renal function is appropriate.
Yes.
There's no impairment, and
Yes.
likewise liver function tests.
Yes.
Any other things that one needs to consider before considering starting a patient on it? Anything else?
I think they're the main two groups, as well as the elderly. I think it's important to say that with kidney disease, when you have end-stage kidney disease and your estimated glomerular filtration rate is less than 30, it's actually a contraindication for ranolazine. And again, these are a very small group of patients who will be within the hospital setting and are often quite difficult to treat. But no, there's no other major groups, no.
Great. Okay. I had this. I thought of getting your opinion.
Yes.
This man who's had a CABG already has been considered again for revascularization, but thought to be high risk.
Yes.
He's already on amlodipine. He's already on bisoprolol, and he's also on isotopide mononitrate.
Yes.
He's still getting symptoms, anginal symptoms.
Yes.
Cardiovascularly, he's stable. His blood pressure is not very high. In fact, it's 110, 120 systolic, diastolic around about 60, 70, pulse around about 60 or below, not higher than that. Would you consider in this particular, his renal function's fine, over 60 EGFR, liver function stable.
How old is he?
He's 73.
Yes. Okay.
He's Asian. Well.
Okay, so he's a gentleman that's had a bypass operation who's got recurrent angina. I think you've done the most important thing with these patients. I think they should come back to the hospital setting to have further revascularization issues explored, which has clearly happened. But saying that, I mean, we need to remember that in this group of patients, whatever we do is largely going to be for symptomatic rather than prognostic benefit. So I think it's perfectly reasonable to explore medical therapy. Now, he doesn't appear to have any real contraindications to ranolazine. I think before I went into giving that, I would want to explore the titration of his existing drugs, the first-line drugs, to make sure that they are at optimal value as tolerated by the patient, and also whether, is he on a beta blocker?
He's already on a beta bisoprolol.
And the resting heart rate is?
Resting heart rate's around about between 50 and 60.
So you've titrated the dose to get the resting heart rate down to the optimal value, so there's no point pushing on with getting the heart rate down further. So I think in this group of patients, ranolazine remains a good drug. There's nothing that contraindicates the patient to it.
He's been advised, but he's been also told the risks are high. So he's wondering what are his options. He doesn't want to continue.
Well, I think if the risks of revascularization are high, we should absolutely explore medical therapy. And I would start him on ranolazine at a starting dose at his age of 500 milligrams twice a day. His liver function, his renal function's normal. I would advise him of the small risk of having gastrointestinal disturbance over the first 2 weeks. I would reassess him in clinic purely for to see how his symptoms have been controlled after 4 weeks. And then you can go up further to 750 milligrams twice a day after that. I think if at that point he remains very symptomatic, it's worthwhile referring him back to revisit the risk-benefit ratio of revascularization.
Yeah, as I say, he's already under the, he's been seen again for revascularization.
But now I think ranolazine would be good for him.
He's not keen on accepting the risk.
That's absolutely fine.
So I just thought perhaps he's already on maximum dose statins, rosuvastatin and ezetimibe. He had his first MI quite young.
Yes.
So,
and again, I think from a practical perspective, we are simply titrating the dose according to symptoms. There's nothing else we need to consider here because there's no renal function monitoring required, heart rate. It's purely going to be with symptoms. So it'll be easy patient to manage in terms of from your side.
Great. Okay. Another patient I thought I'd just share with you. I've already started ranolazine, but I just wanted to see if that's what you would consider as well. This is another Asian lady, 75-year-old. known to suffer with cardiac syndrome X.
Yes.
Has done so for very many years. Again, on nicorandil, atorvastatin, GTN as when required. She's not been able to tolerate beta blockers, even at a lower dose.
Yes.
And we've struggled. And I'm just thinking of other, calcium channel blockers. She's not been able to tolerate either.
Yes.
Edema of lower legs and
Yes.
just had side effects, headaches. So, I was advised to consider, but I was a bit, because she's only on nicorandil and nothing
Yes.
else in terms of anti-anginal. Are there any other options?
Yes, I think the cardiac syndrome X, so these are patients who have angina. Often if you do what's called a functional test, you will see objective evidence of myocardial ischemia, but they have unobstructed coronary arteries. And I think for many years, some cardiologists actually found this a very difficult concept. But the reality is when we do a coronary angiogram, we only see 10% of the coronary tree. We do not see the arterioles, capillaries, and so microvascular angina is much more common than we think, particularly in hypertensive patients and diabetic patients, when strictly speaking they do not have syndrome X, it's due to their underlying blood pressure or diabetes. Now this group of patients should be treated the same way as those with obstructive disease in terms of their angina management. And you've already explored all of the more common drugs, the first-line drugs, and as ever, there's been a combination of some degree of success and some drugs which were not tolerated. So I think you've already explored the first-line drugs, and I think nicorandil is the only one that this patient is tolerating. So you need to go into the second-line drugs. You have options. One is further heart rate lowering with ivabradine, or again, you have the issue of a hemodynamically neutral drug such as Ranolazine. My own personal experience with syndrome X is that this is as effective in this microvascular angina group as in the macrovascular angina group. So again, I think it would be a useful drug. Again, you haven't demonstrated from the history anything that would make me worry about giving this drug.
Great. I mean, I've seen her since, and she does feel a bit better, a lot better. Her GTN use has definitely decreased, and she feels quite happy with it. So.
And of course that would fit with our data in patients with obstructive disease. So I think with these microvascular angina patients, I think ranolazine should be considered as a second-line agent when the primary drugs have not worked or are not tolerated. And
this issue about microvascular ischemia and ventricular myocardial tension, as it were.
Yes.
That's we as in primary care. I was just speaking to a colleague yesterday. Many of us are finding it difficult to sort of understand fully and come to terms with, as it were, because traditional teaching is your coronary arteries are clogged up with atheromas, and if you don't see it, you don't need to treat, or you're fine. But it's actually a bigger picture than that, isn't it?
It's a much bigger picture. I think we should always remember that angina remains a clinical diagnosis. It's based on the history and only the history. And I think if a patient describes angina, they have angina. Now, I think the purpose of testing is to look for major obstructive coronary disease. And if you don't have that, make sure you don't have major valve disease or a cardiomyopathy. But if all of those tests are not showing these things, then you are left with microvascular angina. And this can be this can be demonstrated with either what's called a myocardial perfusion scan or a perfusion MRI scan or a stress echocardiogram, which I do a lot of. So, and what we know is that if you have a ischemic burden demonstrated in this group, you are as symptomatic as if you have macrovascular disease, so they should be treated in the same way. So I think my message for primary care is that the history is the most important thing. If you have angina, you just have angina. And if you don't, if you have coronary arteries that are unobstructed at angiography, you have microvascular angina until proven otherwise.
So thank you very much, Raj. I think you've been very informative and helpful in tidying up some of my queries.
Okay, thank you.
One last thing,
Yes.
we refer patients to rule out sort of angina or confirm and to revascularize. And yes, sure enough, they have their vascularization procedures done and they come back. They still come back, 25 to 40%. I see in my practice. We still left with them presenting with angina, and they're already on Medicaid. What should we be? Should we be referring them back to you?
It's a very good point, and I think again it's something that's emerged as we've collected more data over the years. We often talk about medical management and revascularization as an either or. I think the reality is if you take patients that have revascularization either with coronary angioplasty and stenting or with bypass surgery, over a 5-year period at least 25% of patients will either continue to have symptoms or will have recurrent symptoms. So the reality is in a large number of people we have to consider both as an option, and I would emphasise again in terms of prognosis for stable angina, the most important things to focus in primary, secondary and tertiary care are risk factor control, as you've already pointed out, and for me ACE inhibitors. So I think yes, you're right. I think in this group that are revascularised, my own view would be I would be symptom driven as to whether you refer back. So I would start them on a first line anti-anginal agent. I think if they're continuing to get symptoms, I would then go into a second line agent such as ranolazine, but I think it would be useful to refer them back for an evaluation of their symptoms, ischemic burden, and then we explore other options. But I don't think there's a rush to bring these patients back, particularly if their angina is not very frequent, because revascularization as a second time in patients is very rarely associated with a prognostic improvement.
Right. Okay. Agree to that.
Okay.
Thank you.
Thank you very much.